Thank you for the introductions and hello to you all. I'm presenting a collaborative research study involving Zimbabwe's Ministry of Health and Childcare, local partners, international research institutions, and it was funded by SIF. Adolescents living with HIV experience a high burden of mental health disorder. This is associated with poor adherence to ART. The CATS program in Zimbabwe has been found to improve adherence, viral suppression, and psychological well-being among adolescents living with HIV. Meanwhile, also in Zimbabwe, the Friendship Bench model has found that grandmothers trained to deliver problem-solving therapy, or PST, are effective at treating depression in adults. We hypothesized that by combining CATS and the Friendship Bench, we could improve both mental health and virological suppression among adolescents living with HIV with poor mental health. We conducted a 12-month trial to measure this in 10 districts of Zimbabwe. We randomized 60 clinics, 30 to the control arm and 30 to the intervention arm. The control arm provided CATS counseling services as usual, but in the intervention arm, the CATS had additional training in PST from the Friendship Bench. We enrolled 14 adolescents living with HIV in each clinic who had symptoms of a common mental disorder. We screened a large number of adolescents living with HIV and excluded those who had fewer than 7 symptoms of a common mental disorder using the Shona symptom questionnaire. We excluded a few others who couldn't participate. So in total, we had 421 adolescents at intervention clinics and 421 at control clinics. Follow-up was really good at 91%. Of note, at baseline, almost 40% of adolescents living with HIV screened positive for a common mental disorder. The primary outcome for this study was virological suppression, defined as less than 1,000 copies, and we assumed participants that died were virologically non-suppressed. Sadly, 3 participants did pass away during the trial. The secondary outcomes were the proportion of adolescents with 8 or more symptoms of a common mental disorder on the SSQ. We also looked at depression using the PHQ questionnaire, quality of life, and then we also looked at the severity of symptoms. Viral suppression improved equally in both arms. Where we had standard CAT support, the proportion with viral suppression improved from 66 to 88%. Where CATS had additional training in PST, viral suppression improved from 63 to 85%. So there was no additional benefit on viral suppression from additional training for CATS in PST. Both arms also showed improvements in mental health, but there was a greater improvement in the control arm where CATS had additional training. Almost everyone had 8 or more symptoms at baseline, but after a year, only 2.4% of the intervention group still had 8 or more symptoms of CMD. In the control group, it was 10%. So there's strong evidence that enhanced counselling from CATS led to improvements in CMD. This was the same for all the secondary outcomes, for depression, quality of life, and for severity of symptoms. We also wanted to understand the CATS experience of delivering PST, so we also collected qualitative data throughout the trial. This included transcripts of CATS sessions with their clients, case reviews with CATS mentors, CATS audio diaries, and we conducted 2 FGDs at the end of the trial. PST was difficult for young people to implement, and from the CATS perspective, it was also difficult for their clients. However, we found that CATS adapted it to better fit young people's needs, and the adapted version worked relatively well. So what we're measuring here is a slightly adapted version. As we found in other studies, adolescents' problems tended to be very relational, such as bereavement, abuse, or financial problems. And these are inextricably connected to someone else. And young people often have a very limited control and agency to resolve these types of complex problems and rely on others to help them. This is somewhat different to adults where the model was originally designed for. So the emphasis on the solution aspect of problem-solving therapy, if they didn't have further support to achieve this, could at times be intimidating. Further, both CATS and young people they supported really wanted to get it right. So this was another reason that they found the emphasis on solutions to be challenging. So what worked well for adolescents in CATS? We found that the nature of the intervention created a space and opportunity for young people to talk about problems, and this was really valued. This involved a broader conversation moving away from HIV and treatment to what was actually going on in their lives. CATS were really well placed to provide this trusted and empathetic support. In talking about their problem, adolescents found that their problems and experiences were both recognized and validated. So what we found was really happening was problem discussion therapy, in which even talking about the problem had enormous benefits, even if it couldn't be resolved without additional support. How can it be adapted? Well, it's particularly important to involve significant others in the adaptation, including caregivers and professionals. The quote on the left illustrates where the problem is often related to a parent. The cat said, challenges encountered by the beneficiary are beyond their ability to mention or answer to without a parent being present. The parent is the one whom we need to talk to before talking to the child so that we can help the child. Cats are well placed to take on this mental health role because they have often experienced something similar, but this can make them vulnerable too. As illustrated on the right from one cat who said, when discussing with them about their problems, it is difficult at times, but as a cat, I am not supposed to be overwhelmed by it, as I am supposed to help the beneficiaries. We need to invest in support, otherwise we can make cats or other peer supporters vulnerable and at risk as they take on these roles. What could this support look like? We've come up with this framework for supporting peers to deliver mental health interventions and hope to publish this soon. But key aspects are training, referral pathways, being very clear on the remit of their role, supervision and mentorship, and a recognition that talking helps, even if it is beyond the capacity of young people to solve the problem. In conclusion, we found that viral suppression was improved in both arms, and there was no additional benefit from adding in the more formal PST counselling approach. This confirms that cats who are already trained and mentored as peer counsellors improve viral suppression among adolescents living with HIV, including those with poor mental health. We acknowledge still more needs to be done for the remaining 13% who remained with high viral loads, possibly due to continued adherence challenges or possible drug resistance. Both CATS and the CATS Plus enhanced counselling intervention resulted in improved mental health, but there was, however, a greater benefit where there was enhanced counselling. While we can't attribute this to PST as described, the adaptive problem discussion therapy which CATS actually delivered highlights the need to recognise and invest in the critical role which young lay counsellors have to play in both the mental health and HIV response for adolescents. Thank you so much.